Hello, and welcome to the special summer series of the Things I Want My Daughters to Know podcast. During the month of August, I'll be dropping 2 episodes a week, double the fun. This August, you're going to be hearing brand new episodes that I will be sharing on all my favorite topics of menopause, women's health, symptoms, midlife aging, living beyond menopause, all the things to do with periods and tracking and all those great conversations that we're having with our daughters. And in addition, I'll be dropping extra special episodes on Mondays that come from conversations I had during my online menopause summit. The menopause summit ran for 3 years, from 2022 to 2024. These are conversations specifically around menopause that are still highly relevant for today, and I can't wait for you to listen to them. So get listening. Remember to rate, share, refer, recommend, do all those amazing things that we ask you to do when you're listening to a podcast. But most importantly, have these conversations with the women in your life, with your daughters, with your sisters, with your best friends. Make sure you are sharing your favorite episodes with them. And I can't wait to have you comment and tell me what you're thinking about the conversations I'm having. Let's get on with the episode. Hello, everybody, and welcome back to the Menopause Summit. I am your host, Jacqueline Rose. Today, we are talking about one of the controversial topics related to menopause, and this is the conversation around testosterone. You're definitely going to want to stay tuned to this session. We have the expert on the hormone testosterone, the role it plays in menopause, the role it plays in women's health. We're going to talk about all these things. Welcome, Dr. Angela DeRosa. I am so excited to have you join us today. I am really excited about the conversation that we are going to have. Before we start, introduce yourself, tell us who you are, tell us a little bit about what you do, and we'll jump straight in.
Wonderful. Well, thank you so much for having me. I'm just always so delighted to have the opportunity to open my big mouth and spread the word, anything we can hormonally in women, because it's really been a passion of mine for almost 3 decades now. And I'd love to have just a moment to tell you why I got into this, because I think the why is often very important. And it all started when I was back in medical school in my residency, and I started having a whole host of symptoms that nobody could really put their finger on and explain to me. So a lot of folks wanted to parlay my symptomology into, oh, there, sweetheart, you're in medical school, you're stressed, go on a date night, eat better, exercise more, all that nonsense we tell patients. Yeah. And I was in my mid to late 20s, and I was starting to have the hot flashes, night sweats, severe anxiety, almost to the point of panic attacks. I was gaining weight. I wasn't happy anymore. I was becoming a shell of who I once was, not sleeping really well. And more alarming, I started having arrhythmias where I was passing out when I was working out. And I went to see all the ologists, and I was smack dab in the middle of my training and profession. And I was so discounted and demeaned. And all they could offer me were beta blockers to help with my heart, antidepressants, sleep meds. And by the time I was at 30, I was on probably 5 or 6 medications that ultimately I didn't need, because I went through full-blown menopause at 35. And it became apparent in hindsight that I was going through perimenopause. I was one of those 10 to 15% of women that had premature ovarian failure. And once I figured out what was really happening to me, first off, I was relieved that I could get the help that I needed, because I found true experts that helped me. But then I got really pissed off because I was like, I had to go for the last almost 10 years suffering and being treated like I was crazy. So I vowed that from those days forward, I was never going to allow a woman in my care to be treated like that, and that I was going to dedicate my whole career in the understanding of not only, I'm an internal medicine physician by training, but not only how hormones can help us feel better, but also how they impact and prevent chronic illness. And I've had a really interesting career, because early in my career, I had an opportunity to work for Procter & Gamble as they launched their women's health line in osteoporosis and the development of a female testosterone patch. In those 10 years that I worked with them early in my career, I got to learn from all the international experts on women's health and all of the sexual health, and then it parlayed into hormonal health. And then after 10 years, so in my 30s, I decided to go back to my private practice, and I opened 7 clinics, had the wonderful opportunity to treat tens of thousands and have 15 practitioners work with me. And then I finally kind of slowed down on the clinical side over the last 4 years, because I can really spread the word one-on-one with patients, but in order to really make change, I have to educate others. So I opened a training institute that now trains other clinicians in what I do. And I'm also a medical director for the largest compounding pharmacy in the country, in the United States. So I have all had this eclectic, wonderful career, but it's been purposeful because it all is feeding ultimate goal of trying to make sure women get cared for properly, because we deserve better than what the standard medical profession is giving us. So long-winded answer.
So no, this is amazing, because it's going to lead us into lots of different avenues of conversation. We definitely want to talk about how women and women's health are viewed in medicine, and that's going to be something that I really hope we get time to talk about. But during the Menopause Summit and in this larger menopause conversation, we talk about hormones, we talk about the role of hormones, we talk about the role of hormone replacement. We're normally talking about estrogen and progesterone, and that's great. But there is this other hormone that is there that is playing a role. And I know that you feel quite passionate about it. And I think we really need to open up that Pandora's box about this hormone, testosterone, which for years has had the reputation of being the male hormone, that so many people don't even know that women have this hormone. So many people don't even know why it's so critical to women's health. So let's start at the beginning. What is testosterone? What is it doing in our body? Why is it so important? And why do we need to really think about it in this pot of hormone replacements?
Well, testosterone, as we know, has been very much regarded as the male hormone. But interestingly, what most people don't realize, that on a day-to-day basis, women actually make more testosterone than estradiol. It's our most predominant sex hormone. And it does exactly the same things for us as it does for men. So when they become deficient, they get erectile dysfunction, they get moody, they don't have good cognition, they become fatigued, they gain weight, they have bone loss, all of these wonderful things, or not wonderful things, happen to them. Same with us. Although we don't have the obvious erectile dysfunction, we still get a lowered libido. The clitoris isn't as sensitive as it once was. Our orgasms become blunted. And honestly, most women just don't want to have sex anymore, period. But also it affects our cognition, our memory, it affects our mood. It's Mother Nature's serotonin. So we become anxious, we get depressed, we get irritable, we start having new onset panic attacks. It also affects our ability to have energy and burn and have oxygenation and endurance and working out. It is essential for glucose metabolism. When we lose our testosterone, we don't process sugar anymore. Testosterone is what moves sugar from the bloodstream into the muscle so it can burn cleanly, which is why men lose weight faster than this. They have more testosterone and more muscle. But if that can't happen effectively, then the pancreas kicks in and has to do more work, which uses insulin, which loves to store that glucose as fat in our midsection. And then it leads to prediabetes, diabetes, and heart disease. And when testosterone is low, we're also at increased risk of breast cancers and other cancers because it's a highly inflammatory state. So it does so much for us. And honestly, if we start to compare the symptomology, it's identical for men and women.
Right.
But if a woman walks into a clinic with those symptoms, she's going to get an antidepressant, where a man's going to get their testosterone. And it doesn't get the just dessert that it does deserve in women, because it is essential for our overall health and not only feeling good. Because if you put a gun to my head, hands over estrogen, I'm going to take testosterone every day, because it does so much more for us in a lot of ways than estrogen does. Not to say that estrogen isn't important, because it is, but testosterone is as important, if not a little bit more, because of its role in glucose metabolism.
In glucose, so I want to go back to that. But explain to us what would be the natural, or what is the natural testosterone journey over our life cycle? When is it high? When does it start to go down?
Yeah.
We know that estrogen is doing this crazy fluctuation in perimenopause and menopause until it reduces. But what are the expectations of how testosterone should behave, assuming you're an imbalanced, hormonally healthy woman?
So when we look at basically hormonal transition, so let's assume for a second the average age of menopause is 50. So usually that when I define menopause is basically the ovaries stop working. Elvis has left the building, they're retired, it's kaput, it's done. But it doesn't do that overnight. It does a slow decline in function over actually a 10 to 15 year period of time. So it's always ridiculous to me when I hear providers tell women, oh, you can't possibly have hormone deficiencies because you have regular periods or you're not in menopause. Well, the ovary slows down gradually. So you can absolutely have regular periods and have hormonal decline. So when you look at all of the hormones and how they sort of decline, Mother Nature was actually very, very smart. And biologically, we think women are stronger. We are, because we have to take care of children. But estrogen is really savvy because it stores itself for a rainy day in our fat cells. So it's going to lag behind testosterone because testosterone does not store anywhere. We make it, we use it, it's gone. So I always say testosterone's like cash, estradiol is like having a savings account. So when you look at the decline of those two hormones as the ovary fails, you're going to lose them at different rates. And mind you, 95% of our testosterone production comes from the ovary. The other 5% comes from the adrenal gland. So as the ovary slows down, you're going to lose that testosterone, the 95% of it, rather quickly. And it's actually the first hormone to go. It usually starts to present as a deficient state in our mid-30s. So mid to late 30s is typically when that presents. So women present to the doctor's office with all those symptoms, they get labeled as depressed or fibromyalgic. Once a woman comes in with the hot flashes, the night sweats, the vaginal dryness, all the insomnia, all those estrogen deficiency symptoms, they are already testosterone deficient. So it usually starts mid to late 30s for testosterone, the estrogen in the 40s. And then when our periods are getting erratic and irregular, that's when the progesterone deficiencies and destabilization and imbalance is occurring. And then once the ovary shuts down, they all go, and with the exception of that little 5% of testosterone coming from the adrenal gland, but it's often not even close to what we need on a biological need to function day to day.
So what type of testosterone support, or what type of testosterone levels are we ideally looking for as we navigate into menopause and postmenopause, with that understanding of the role that testosterone is playing in all these primary essential functions in our body? What should we be looking for then?
Well, typically when we look at blood levels and symptomology, that's what we really want to use, that combination. So we always want to look for those symptoms: the low libido, the depression, new onset mood disorders like anxiety, panic. Are we having new onset migraines? Because that's often a symptom of testosterone deficiency. Are we tired all the time? Do we have insulin resistance? Are we gaining the weight in the midsection? So those whole host of symptoms start to present, and that's what we really have to pay attention to. Then we can look at blood levels as a guide, but the problem has always been with female testosterone labs. The labs are not very good. They're not very accurate, and the sensitivity to a much lower level that we have compared to a man is more difficult to assess and ascertain. So when you actually look at a lot of the studies, in particular, Rebecca Glazer did a lot of work out of Ohio. It always showed that the testosterone levels didn't directly correlate with symptoms in women. And we really need, which makes it challenging, but even when you look at ACOG and ACOG, they always say don't treat to lab levels, typically base it on symptoms. So when you're treating testosterone, we're going to treat to the dose and level that gives the effective symptom improvement without having side effects. So, I mean, if I have to pluck a chin hair here and there, I'm not going to be too worried about that. But if I have a fulminant beard and I'm turning into a Sasquatch, then we've got a problem. You know what I mean? So watch for those testosterone excess symptoms while treating to the high levels.
And some of the symptoms that you described are often attributed to low estrogen or estrogen fluctuations. So, You may go
Yeah.
to your doctor, and because estrogen is always considered the first line of hormonal support, if that's the direction you're going in, testosterone isn't getting a look in. The symptoms sound quite similar to requiring estrogen support. So testosterone is really left on the wayside and totally ignored.
Well, if you actually start to break it down, there's a slight bit of overlap, but there's very distinct boundaries. So if you look at estrogen deficiency, the hot flashes, the night sweats, the vaginal dryness, the insomnia, that's not going to be a symptom of testosterone deficiency. But low libido, lack of clitoral sensitivity, decrease in orgasm strength is not an estrogen deficiency. It may cause vaginal dryness, which can cause pain, but it's not going to cause those symptoms. Estradiol is not going to affect insulin resistance. That's going to present there. Migraine can typically be a testosterone symptom, but it can. So the key is when you're dealing with hormonal medicine is how to separate out all those little pieces, because even thyroid imbalance can present with similar symptoms. And you just have to figure out the ones that have no overlap to make sure, and then using your labs as a guide. So typically when you look at lab reference ranges for testosterone, they go up to about, on average, let's say 15 to 70 or 15 to 60, depending on the range. But most women start to exhibit symptoms under the level of 50. So if they're coming in their levels under 50 and they have a whole host of symptoms, I'm going to treat that person. But if they're fine, their levels are good and they don't have any symptoms, we don't treat those women yet. So the key is to address it based on each individual patient and not just base it off of numbers, because they often can fail us.
Okay, I'm going to leave to the how do we treat and support testosterone to a minute. I just want, because you mentioned the thyroid, I do want to just talk about, you mentioned how testosterone impacts symptomology. You did mention insulin resistance, you mentioned glucose metabolism. I want to just understand a little bit the role of testosterone in these systems of our body. You mentioned thyroid, glucose production, cholesterol, insulin resistance. We normally know and talk about estrogen's role in a lot of these things, but I understand that testosterone is playing a significant role here also. So can you just talk to us about how testosterone is supporting a lot of the system bodies, because that's going to help us understand the long-term benefits or the longevity health benefits of testosterone.
And I'm so glad you asked that specifically, because it's really been as an internist, I really wanted to understand the impacts of chronic illness and different disease states that could be resultant from deficiencies in these hormones. So if we kind of like start to break it down, first off, bone health. So estrogen actually prevents bone loss, but testosterone lays bone down. So it's a very powerful anabolic bone laying agent for bone health, where obviously estrogen is as well. When women lose their estrogen, they lose bone very, very rapidly. But when you have the double whammy, it's a bad combination. So bone health is essential. So then if we move to, say, the cardiovascular system, when you have estradiol deficiency, we typically will see endothelium. So the inside of the arteries start to harden, which leads to high blood pressure. And also estrogen is very vital to keep our HDL, the good cholesterol, up and the bad cholesterol is in balance. Where testosterone can have some effects on triglycerides. And actually testosterone, even a lot of the men's research, show positive impact on those parameters, which is counterintuitive. Most people think they're bad for them, but it was the synthetic testosterones that were bad, not bioidentical. So then when you move to the glucose metabolism, estradiol can help with some weight control, but testosterone is the most direct link to glucose metabolism based on its impact of moving glucose effectively into the muscle. So what you'll often see when testosterone drops is our hemoglobin A1C, which is the blood level that screens for diabetes, starts to rise. And when you get to, say, over 5.7, you're pre-diabetic. And when it gets over 6.2, you're diabetic. And we see those levels rise into the pre-diabetic all the time. And what's really cool, when I start treating my patients with testosterone, those normalize, and very, very quickly within a month of treatment, which then helps our body lose that insulin resistance. Because if you stay down that path, it leads to all kinds of problems in cardiovascular, stroke, amputations. And the problem is we give people medicine and nobody gets better,
Yeah.
and it's a horrible pathway. But if we stop it at the root cause, we can reverse it, which is so powerful. And then you look at its role in cancer risks. A lot of folks have a great deal of misunderstanding around hormones and cancer risks. And when your thyroid is down, or your estrogen's down, or even your vitamin D or testosterone, those all create inflammatory states, which is what really drives cancer. And testosterone specifically, when it comes to breast cancer, is really fascinating because estradiol can have a role in breast cancer. If you have an active cancer and I put estradiol in the system, that potentially could grow the cancer that's there. But testosterone actually blunts that growth. And we used to use it to treat breast cancers. Dr. Rebecca Glazer has done some wonderful research with patients undergoing active cancer treatments who get testosterone. They have a lower recurrence rate than those who don't get testosterone. And she's even done work where she's thrown testosterone pellets into the actual tumor in the breast and watching them shrink.
Wow.
So the data is very, very powerful that if women are on testosterone, they have a lower likelihood of developing breast cancer. And if they have cancer, they're going to have a reduced risk of recurrence if they're taking testosterone. So, and we don't talk
I'm
about
so
that.
happy you mentioned that, because I heard you mention that in the webinar that I watched with you. And I'm so happy that you've repeated that research finding, because it is, no one knows about it. And it would seem that people would be, and maybe this sort of will lead us into this total gender bias around women's health in the medical field, that why are we not talking about this? Why are we not saying the long-term health benefits and the cancer health benefits of testosterone?
And think about it, 1 in 8 women are going to develop breast cancer in their lifetime, regardless if they're on hormones or doing anything or not. Actually, being overweight and drinking or a flight attendant is going to confirm way more risk than anything we ever do on this side. But what is maddening to me is when women undergo those therapies, basically we're taking their estrogen out of their system and they feel horrible. But why, if we can give testosterone back, we give them a large degree of their quality of life back, and we reduce their risk of cancer recurrence. It's maddening to me that this isn't standard protocol of care in the oncological side of things. And I just don't understand why. To me, it's like
I'm going to,
right.
So I'm going to challenge that. I know we still want to get to testosterone hormonal treatment. We're going to get there, but I do want to challenge you. And maybe this is the time to sort of open up that Pandora's box of the way that women's health has been viewed traditionally in the healthcare system. Because I think this is one example of the fact that we know that women's health has been under-researched, underfunded, underrepresented in medical training programs, in the healthcare system in general. We know that even women's health conditions like PCOS or endometriosis, it can take between 5 and 11 years to be diagnosed. Let's maybe share your thoughts about that.
Well, here, just to give you just a glaring example, I mean, the Department of Health in the United States, or the Department of Defense, excuse me, in the United States, has invested billions of dollars in Viagra for their people, but we can't even get hormone therapy covered in insurance plans for women. It's just ridiculous to me, and actually horrible. But when you start to think about the gender bias that's going on, there are many, many examples of it. And if we start specifically with testosterone, men, when you look at the trials for testosterone, or even the trials for Viagra, they never did randomized controlled trials. They just automatically got them approved through the FDA. And there's lots and lots of different products for men. But for women, we don't have one FDA approved testosterone product, because the studies we did over at Procter & Gamble when I was there was one of the cleanest data sets I've ever seen. And we just maybe got a little bit of chin hair, which is to be expected. And everybody was all up in arms. It's like, oh my gosh, is this really safe? And we did all these randomized control studies that showed that it was safe, but yet the FDA wouldn't approve it. So you can give a man drugs that could literally kill them, and that's okay. But we can't get a testosterone preparation because of chin hair. But where does all that bias come from? Well, when you look at actually clinical trials, it's very, very difficult for clinical trials to be studied with women, because we have so many hormonal fluctuations, which complicates.
Right.
But also there's always the risk that if something happens and a woman gets pregnant while they're in the trial, that it could be a liability for them, and nobody wants to take those additional risks. And why testosterone, when we were doing the research, they honed it in women who didn't have a uterus, because testosterone is considered a category X for pregnancy. So they wanted to make sure that the women who are on these testosterone trials didn't get pregnant when they were studying it. And one of the things I've also learned, when drugs go to trial, that you need to be able to patent it, number one. So bioidenticals will never, ever be patentable. So companies aren't going to take bioidentical hormones to trial because they would lose their money on the other end. But also, when you're studying these drugs, you want to make sure that it can be done safely, and you also want to make sure that you can get it approved and get the study to prove a point. So they always narrow the indication down to one very specific or two minimal things, which is why they studied the testosterone patch for sexual dysfunction. They didn't study for it for all those other things because it would make the study so large and difficult to statistically approve. So they went for the easy get. And they actually proved that it did work for that. But that's why when you see a lot of these guidelines, they say, oh, you should only use it for this indication because there's no research to study it here. But although there's all kinds of observational studies and biological effects that show that. So there's this inherent bias, but that people don't want to study research on women, but also we're expected to stoically go into the night after menopause. But God forbid you stand between a man and his penis, because they get everything they need.
Exactly.
So there's tremendous bias, and it starts with the pharmaceutical companies and the dollars because unfortunately a lot of these industries are still largely run by men, but you would think they'd want us to be happy, but I don't understand it.
I know. It is a very confusing and frustrating piece of the puzzle. So you mentioned the testosterone patch, and the fact that there is no FDA approved testosterone support for women. Let's talk about how women are able to support their testosterone levels. What is available? What is being prescribed? I know that in Australia there are some things being prescribed. Share with us a little bit about what hormonal support looks like, and then if you're not getting the hormonal support, how else can we support our testosterone levels?
Right. So it's very challenging without getting actual testosterone to raise your testosterone levels naturally, with the exception of maybe some supplements like DHEA is a precursor to testosterone, so that can be utilized. But the problem with DHEA, when you get to higher levels, it can cause considerable what we call androgenic effects, the acne, a male pattern baldness, the facial hair. So we have to be really cautious with the doses. Usually I cap out at 5 milligrams, but some people go up to 10, 20, 25, but that can be very problematic. So there's very few ways to actually naturally increase testosterone other than replacing it. And it goes to the problem is that we don't have an FDA approved product. So I was actually presenting in front of an FDA committee about women's health and testosterone, and they actually asked me, and I took everything I had to keep myself composed. They're like, why do we even need a product for women? We have ones for men. Why don't we just use those?
Right. Which is what we do, which is exactly what we do.
Asinine, inappropriate thing to do, because physiologically we're different and we require different dosing and different strategies. So some people say, well, just use the male products in micro doses. And that's one way to approach it. However, I don't support that. But this is where I think compounding pharmacy can really play a huge role, because it fills the gap that's not met in the commercial space. And for those of you that don't understand a lot about compounding, there's a lot of negative press around compounding, but compounding serves a great need. And the level of scrutiny and regulation that goes into the big compounding pharmacies is insane. The compliance, the complexity, it's to the level of almost a pharmaceutical company, if not even worse.
Explain to us what a compounding pharmacy is, and explain to us why there is so much controversy around it. I have my own thoughts, but share your thoughts as to what compound pharmacy is and why it's being so vilified.
Right. Well, I'm going to tell you the diplomatic and then the not so diplomatic answer to that. But so that's just to complete the point, though, on the testosterone, that's where I get my testosterone for my women, through compounding pharmacies, because that's the source that we can get it made and fill that gap. Now, to your point, so what's the difference? So a pharmaceutical company, so I'm going to use the analogy is like going to McDonald's. They have their standard process, the standard dose, the same exact thing. So if I want a Big Mac, I go to McDonald's, everybody gets the same Big Mac. The same thing with hormones. When you go to a pharmaceutical company, they're going to make it identical in major, big, huge batches that everyone's going to get the same dose, and they're highly regulated for that exact molecule. Now, imagine compounding is kind of like going to a Michelin star restaurant. They're starting with the same active FDA approved ingredients as you would at a big pharmaceutical company. However, they're taking little bits of each of it and they're mixing it and blending it and making it a fine, specialized, personalized meal for that particular patient hormonally.
Right.
They both start with very regulated, highly FDA approved, inspected products that go into them. But the pharmaceutical company's making it exactly the same, where compounding has liberty to individualize it to that patient. Both industries are highly regulated. And when the company that I work for, you would not believe the compliance and the sterility testing, the third-party independent testing for endotoxins to make sure it's what we say it is, that it has all the ingredients. And even now, all of the ingredients and the vendors that are used have to be FDA certified, and everything that goes in. So there's so many steps and regulations that it's as regulated as the pharmaceutical industries are. And actually they undergo audits much more frequently than the pharmaceutical industry. So they have to be really, really good now. So they serve a really good purpose. The problem is, okay, so some people are going to say, well, you can't regulate every single batch that comes out. Well, that'd be impractical. Of course you can't. But then people want to say, well, you don't know the potency or the sterility of all that coming out, but they're speaking out of turn because there is nothing further from the truth now. The regulations, in particular in the last 2 years, have gotten very steep. My cynical point of view, and why I think a lot of people are trying to shut down compounding pharmacies, is all about power and money. Because if women are on hormone therapies, we don't need sleep meds. We don't need antidepressants. We don't need bloods for our blood pressure. We don't need statins. We don't need there's a $1 billion industry off making money off the backs of our health to keep us on drugs. And in addition, if women are on those hormones, the pharmaceutical companies aren't going to make the money that they want. And why they're trying to particularly shut down the hormonal side is because the hormonal pharmaceutical companies took a huge hit when women started moving in this direction. And unfortunately, although you have a lot of these society guidelines that don't support compounding, but keep in mind, a lot of those societies are largely funded by pharmaceutical industry. So it's a huge conflict of interest. So actually, when I look at the data worldwide, the United States has highly conflicted data because the large majority it's coming from big pharma. Where other like other places outside of the US, they have a lot of university based, which you get more reliable and less conflict.
It's such I think it's really more about the politics than it is about the science. Big pharma, for good and for bad, they may do some amazing things, but they really control the drug industry. And when there are these compounding pharmacies that are making things that are much more personalized, and obviously there may be smaller compounding pharmacies that maybe are getting even a worse rap than the more recognized and bigger compounding pharmacies. But this whole personalization, the whole thing that they are doing, that they do very, very well, is one of the reasons why they're criticized. But obviously they're taking away attention and money and focus from big pharma. So I think it definitely is more, as you've explained, much more about the politics than the science. And at the end of the day, it's the women who are suffering.
Exactly. And it's not to say that the FDA doesn't have a role or big pharma doesn't have a role, but so does compounding. And why should we wipe out that one side of it because of power and politics? And it's an important piece that it's filling that need that big pharma is not meeting for women, and in particular with testosterone. And God forbid that they go away, we would be left without it, other than having to use male products, which are completely physiologically inappropriate. So it's alarming to me that there's this effort to dissuade folks from going in that direction when they're actually a very vital part of our women's health armamentarium to be able to treat women.
Are you familiar with what's going on in Australia and in the UK with respect to testosterone?
Well, it was my understanding that it was, I want to say about 2 years ago that they had a gel that was approved in a testosterone, but it's also, and I'm hearing is they're trying to take it off the shelf too at this point for women, which I don't understand why that would be occurring. But at least they have something, but that gel, I mean, unfortunately, certain products work better than others, and those gels, and typically the pharmaceutical ones, tend to be very low dose. They have very minimal effect. Gels can rub off on other people and pets, and they can smell, and they're sticky, and they honestly just don't work well. Whereas I look at fast burst sublinguals, which go under the tongue, those can work effectively. And then my favorite is the hormone pellets for testosterone, for all my hormone, estradiol and testosterone, but testosterone specifically, because it does a slow release and it's the most physiologically mimicking.
You mentioned research about the testosterone patch. That does not exist today. It's not available. What do you?
It was for a period of time. We were unable to get it approved here in the US, which is a travesty because unfortunately the was coming on the heels of the Women's Health Initiative study and the Vioxx scandal that just broke that they had to do a huge mea culpa on. So I think the FDA was skittish at the time, but we did get it approved in the United Kingdom and Australia for a period of time. And unfortunately, I think some of that's backtracked at this point.
Yeah. I think there really is an understanding by a very few select doctors who understand the role of testosterone, but it really is not accepted. I mean, accepted across the medical spectrum of the benefits of testosterone. And yes, and as you've said, the way that that you can really access testosterone today is either get testosterone for men and use a smaller dosage, or just wing it.
Compound, which is what
or compounding
all of my patients get compounded testosterone. The majority of them are getting pellets, and then I have a smaller percentage on the fast burst sublinguals or creams, but I refuse to use the male products. It's to me, just on the surface, and the thought of us being forced to use men's products makes me apoplectic.
So you did say that if you had to choose, under with a gun to your head, if you had to choose what hormone, one out of all the hormones, you would recommend, and you do recommend, starting with testosterone before you even touch the others. And that's really quite revolutionary.
And don't get me wrong, I love estrogen and progesterone in the right application. And I personally also take estradiol and progesterone in addition to my testosterone. But there's very, very little or few indications that would prevent me from starting testosterone on anybody. I mean, it's a very, very safe hormone. If you have uncontrolled sleep apnea or a testosterone tumor or just some minor other things, there's very few reasons you can't. Even like I said, breast cancer patients, we can start it. But estradiol, we have to be a little more careful. If they're 10 years from menopause and they have severe heart disease or cardiovascular risk, or they have an active breast cancer, we can't always use estradiol. And I love my estradiol. It helps me with my vaginal dryness. I don't have, I mean, I still get hot flashes and they make me crazy, and I need my estrogen for that, and also to sleep so I don't get the night sweats. So I think estradiol is important as well. I love all three. And then you need progesterone to balance the estrogen if you have that. But if I only had to choose one, I would take testosterone hands down, just because of it has such a unique role from a cardiovascular risk and that insulin resistance. I can always tell when my testosterone levels are dropping after I place my pellets. I get migraine headaches that start to trigger. It takes me longer to process information. I'm just not cognitively as sharp. I get irritable and moody. I don't want to have sex. I'm exhausted. So in those cases, I could deal a little bit with hot flashes and night sweats if I had this part covered. And oh, by the way, I'm reducing my breast cancer risk in the meantime. You know what I mean? I love my estrogen, but I love my testosterone a little bit more.
Even more.
It's like Sophie's choice.
Right. And is the recommendation to take testosterone, until the day you die? Is that the recommendation? There's no stopping after when you're in postmenopause?
Well, see, I think the recommendation of stopping using the littlest amount of dose of estrogen for the shortest period of time is actually biologically ridiculous. It makes no sense to me, because I am not here to treat women's hot flashes and get them through that transition. I am here to help them with their symptoms, but also keep them healthy in the long run. If I stop their estrogen, their blood pressure is going to go up. They're going to start to have cholesterol abnormalities. Their heart disease risk goes up. They're going to have vaginal dryness, urinary incontinence, urinary infections, dementia risks. And there's a whole host of things that occur. This is not just about symptom relief. For me, these molecules are powerful tools in my armamentarium to prevent chronic illness. Why on earth would I stop them? And we show time and time again, the second our hormones go away, we rapidly age, not only physically, but also from a medical physiologic standpoint. And interestingly, because doctors always ask me this question, and I just want to give you a little bit of insight into this, is there's this hormone called FSH, follicle stimulating hormone. And when your hormones drop, the brain pumps this hormone out in large amount of levels. And this is how we can tell if women are in menopause if we don't know their period status. That hormone goes really, really high when we're in menopause. And why it does is FSH is a whip designed to go beat the heck out of the ovary to make hormones. And till the day we die, that hormone level is going to be up really high, beating that basically a dead horse, because the ovary stops when we go into menopause. But until the day we die, the brain's going to try to correct it. But we ignore it. But every other endocrine system where we get that signal, TSH for thyroid, we jump all over when that happens. But why are we ignoring it when it comes to our ovary? It's our body telling us it needs those hormones till the day we die, and it's going to attempt to try to correct it. But in medicine, we just say, oh, go ahead, deal with it. It's not important, but it is very important.
Well, you know my answer as to why it's ignored, because of the way that women are viewed, the way that aging women are viewed, the way that, you know, the relevance of women is that, okay, fine, you've stopped producing, you know, your ovaries have stopped, your reproductive systems have shut down. Okay, that's what's meant to happen. That's the end of it.
You're irrelevant.
You know, goodbye and good luck. So
we can't have babies anymore. Why does it's Mother Nature is saying, well, you can't have kids anymore. We're irrelevant biologically, so bye-bye. But that's not how it works in humans.
And especially today, when women are living 30, 40 years longer, in postmenopause, and also when we know that
absolutely,
and I think it's also changing this Western perspective of aging, because we know in other cultures it's not the same, that we have completed that life cycle stage of reproduction, creation, but now we're moving to the next life cycle stage, and we want to make sure that we are healthy and well and strong in that next postmenopause life cycle stage. And that is beginning to really change the conversation around what menopause is representing and how we want to stay healthy and strong as we age, which is, you know,
absolutely. I'm not going quietly into the mix.
Exactly. Well, you've given me so much of your time. You've shared such important information. As we begin to close this conversation, I just want to ask you if there is one thing that you could shout from the rooftops, one thing that you could, you know, shake your woman in front of you and say, you just need to know this. I wish you knew this. What would be the one thing that you just want women to know about this whole menopause experience?
It's not to suffer. And really, honestly, is that there are doctors, there are resources and places that you can get the help you need. And I always tell women, trust themselves, trust their bodies, because they know them better than anybody else. And if you know something's wrong and somebody's telling you something that doesn't resonate properly with you, keep seeking answers and don't accept what you're being told, because it is the women that are going to change the face of healthcare. It's not the physicians or the providers. We need us to advocate for ourselves and push back. And know that when it comes to hormonal health, make sure you're getting people who know what they're doing. Don't assume your standard primary care is the doctor who can manage it, because oftentimes they're going to tell you you're fine when indeed the levels aren't fine, because they don't know how to properly interpret thyroid or testosterone levels or estradiol, FSH levels, all of those things. So seek answers and seek it from the best sources, which are hormone specialists, functional medicine doctors, integrative health specialists, all those key tag words you can think about, but find those people and get the
Yeah.
answers you deserve.
Yeah. I think that's really important because we know that women go to their doctors, they don't get the answers they want or they need, and they just sort of leave that doctor's surgery
Yeah.
and think, okay, fine, that's what the doctor said. So that's what the doctor said.
No.
But there are people out there like yourselves, like other, real pioneers who are there to change that conversation too. So I really, really thank you for the work you're doing. It's really so critically important. I'm so, so honored that you were able to join us today and to share your wisdom and to really open that conversation about testosterone, because we need to be having it more. So really, I really, really appreciate you joining me. Thank you, Dr. Angela, really.
It's my pleasure. And thank you for having me and allowing me the opportunity to spread the word. So
definitely. Well, and thank you everyone for listening and for joining us at this session of the Menopause Summit. Join us for the next session. Lots of really interesting conversations happening. Looking forward to seeing you then.